So thank you very much for everybody joining today's session. We're very honoured to have Professor Alistair Hall, who is a Professor of Cardiology, but is also the Clinical Director of Yorkshire and Humber CRN, to come and talk today about how the CRN can help us in our research. I'd just like to remind everybody to keep your microphones muted when we're not speaking, just to be respectful of everybody else. We will be doing a Q&A session at the end of today, so you can either write your questions into the chat or you can raise your virtual hand at the end. So I'm just going to hand over to Alistair, and thank you very much for your time today.
Thank you very much. Carol, can you hear me?
Yes, I can.
Take that as a yes. And do you want me to run through these housekeeping rules? No, you've just done that. Okay, so if we have the first slide, please. I'll be doing next sliding, please. So the Clinical Research Network is not correctly named because we're now more than clinical. We began as an NHS arm to do with patients only, but we've now been extended into well-being, which is healthy people, and end of life and non-NHS and social care settings. So the word clinical is a broad term and maybe it needs to change. Yorkshire and Humber you'll be familiar with. And the picture we're looking at is Bradford, and you'll know that a lot of Yorkshire does look a combination of green and industrial. Leeds in particular began as a place where sheep were shorn and turned into wool and then turned into cloth, and that was sent round the then British Empire. So that's the environment we all practice in, and it is relevant probably to when we talk about the network. It does characterize us as a network in a slightly distinct way to the other 14 regional networks which exist in the UK. Next slide. So we're the red bit in the north, and we are the second largest network in population terms. I think we're maybe the largest in geographical terms. In terms of money, we've sort of been narrowly third. Up until this year, we were getting about 26 million a year. This year it's gone up by 3 million, and I'll tell you about that 3 million in a minute. But when the current network came into being, it was an amalgamation of 3 Yorkshire networks. The West Yorkshire, the South Yorkshire and the North East Yorkshire networks were combined, but also so-called topic networks, which were disease-specific: cancer, diabetes, primary care, mental health, among others. And a combination of all of those networks into the one clinical research network. So that was 2014. Something that probably makes us distinct from other parts of the National Institute for Health Research, including biomedical research centres, is we are expected to reach everywhere. All parts of the region, all parts of the healthcare system, every disease that's known to man. And as I say, now we're given the brief of prior to disease, and indeed once curative options are gone and only social care options are present. So the nature of a network is that it is a hearts and minds venture as opposed to a top-down. Although during the last year of the COVID crisis, we have been asked to behave a bit more like an army and march to instructions from above, both nationally and regionally, to rally around vaccine research hubs and other activities such as that. Next slide. So on the left, you'll see a Rolls-Royce engine, which previously was put on an airplane, and that was the end of Rolls-Royce's job. They had sold the engine based on a contract. It was a transactional relationship. But then, like other companies, they decided there was a different way of doing business. So now every airplane that flies with Rolls-Royce engines doesn't actually own those engines. They still are owned by Rolls-Royce, who actually monitors them with telemetry all around the world. And if one of the engines is looking to have a vibration or something, they can see it first and ring the pilot through sat-nav and say, when you get to New York, we're going to just check that engine. Can you reduce it? So they're offering a service and solutions as well as, and of course that's good for their business. They don't want a plane malfunctioning with one of their engines. But the network's been the same. It sort of began very transactionally and with contracts, handing money out to multiple partners. and trying to be managed through metrics and performances. But we have moved, and especially during the pandemic, into being a lot more transformational, meaning we're moving out of a purely metric-driven financial contracts environment to being a lot more creative and strategic in problem solving, which is a lot more gratifying. In reality, we have to do both. Those blobs indicate money, which was largely just handed through us to partner organisations. But we do now have a strategic part as well. That always existed if we had an underspend or otherwise found an economy, but now there is intentional strategic spend each year. Next. Thank you. So in the last year, we had 170,000 members of the public agree to take part in research, and that more than doubled our last record amount. And we were always the first network in volume, but we were clearly the first this time. And that was a surprise. We thought the pandemic would mean we would dip to, maybe half the volume of participation. So that's an interesting statistic. And it certainly fits with the idea that people understood why research was being done. There's a crisis, it's ruining their lives, it's stopping the world from spinning, and they'd like to be part of the solution. And many, of course, would like to avail themselves of treatments at a time when otherwise there were few evidence-based treatments. We have other quality metrics, which you just need to look at the green ticks, and we managed to do well on that this year, but they are things like percentage participation of organizations, time to set up, etc. Rather boring, really, but that's part of the transactional bit that we have to do. The two in orange were just near misses by about 1%. And we're being reset like the rest of research, like the rest of the NHS and community, by the COVID pandemic. But we do believe that we're at this inflection point where we're moving from good to great, as you've seen with audience participation. But there's other reasons to believe that we're actually changing quite substantially how we're operating and how we're impacting, which I'll tell you more about. But you'll see the clue there, place-based research. Used to be we had siloed partners, let's say in Leeds, let's say 8 different partners or many more with GPs that really didn't work together. But as soon as we had a vaccine hub, we got contributions from all those 8 partners, and indeed people travelled from other parts of the region to help. And that's what we refer to as place-based research, which is crossing boundaries and just really tackling the problem that's in front of you. Next. So the mission of the NIHR, of which the BRC is part, is to improve health and wealth. I used to have a problem with the idea of the wealth part of this statement, but since this job and looking at the epidemiology of health, of course, there's a 10-year shorter life expectancy if you're in the most deprived part of society, socioeconomic class 5. So there's no question that wealth improves health, and clearly health also improves wealth, and we accept that as part of the nature of life. The governance is 6 main coordinating centres across the NIHR, but at the top is the Department of Health and Social Care. And so really we are a government department, or we're under government direction, which is important to the dynamic we have to respond to. NIHR, as you can see, is an important part of the landscape, but it has the word there supporting NHS research, which was the original intention. But you'll see bottom right, there's many other places where health interventions would be important, such as care homes, prisons, schools, dentistry, surgeries, hospices, and just within the general public. And those have now been incorporated in the mission, even though that statement hasn't yet quite said it. Money to expand our remit, however, only just arrived this year. Next slide. So you'll understand that Chris Whitty is now a pop star and has his own mugs, which you can get from Amazon. This is the advert part of it. So, and he is the head of the NIHR, along with Louise Wood, and they've just released yesterday their best research for best health, the next chapter, which is the NIHR vision going forward. And of course, the CRN is a big part of that vision. Next. So there's always been these different work streams, but without looking at the detail, which you can just download this this paper from the internet, just look at the summary statement, which is working with partners the NIHR needs to tackle the ingrained injustices that exist in the world of research in terms of those who are involved and engaged and participating, and also the inequalities which exist in the professional research workforce. So there's a real social consciousness in this forward-looking agenda, which I welcome, and I'm sure you do too. Next. So if we move from that overall vision, there's a breakdown in this, which I can't see from the screen to read out, so I'll just check on these notes. Yeah, the first one I've highlighted NIHR in community settings, such as homes, schools and care homes, just to show you this broadening reach, to support public health and social care research. The third one down talks about social care settings again. And yeah, the logic of this, I think, hopefully is apparent, but mostly because we're an offshoot of the Department of Health and Social Care. And again, the pandemic, you know, it hit both the health service, but it also hit the care homes. And generally speaking, social care has been underfunded over the last years, as has health, to be honest. And the solution is to try and integrate them in terms of service delivery, but also now in terms of research. Next. So the intention is to build on learnings from COVID, to build capacity, particularly in the public health space, social care, and that's our brief as a network, to improve the lives of people with multiple long-term conditions and multimorbidity, which is a new emphasis. We've tended to be very select specialties and many subspecialties within those, to bring clinical and applied research to the underserved regions, and those would often be socially deprived areas, but whole geographies, often away from the teaching hospital or the university, can be left unresearched or eligible for inclusion. Embedding it in the normal culture of care delivery and indeed just society in general. So these are some of the intentions of the NIHR going forward. Next slide. So the summary of the document, they've set out, consistent with the mission, NIHR funds, enables, delivers world-leading health and social care research that improves people's health and well-being and promotes economic growth, hence health and wealth again. And the well-being means people who aren't ill yet. Prevention, upstream public health, and of course we don't refer to participants there as patients but as participants, because they're usually not yet patients. Next. So this slide was borrowed from the academic health science, but it does just summarise the Yorkshire region, 20 acute trusts, 6 teaching hospitals, 5 mental health trusts, 22 commissioning groups, 770 GP practices, and 3 so-called STPs, now called integrated care systems, which basically are sub-regional areas where there is shared care, and that includes social care. And it's a change in the NHS organisation that is moving quite rapidly forward. We have 3 of those sub areas: West Yorkshire, South and the East, Humber, Coast and Vale. Overall, our entire population of Yorkshire and Humber is 5.5, but most of that's in West Yorkshire, 2.6, with just over 1 million in South and the East. There's a significant health spend, but probably more important are the statistics at the bottom. 3rd lowest life expectancy for both men and women, high obesity levels, 2nd highest infant mortality rates. And if we actually went to the next slide, you'll see some of the economic statistics, and we represent 7% of GDP, and yet we're 10% of the population. So that shows that we're relatively not bringing in the income to our region for our people that our population size would suggest would be possible, which should be more 10%. Of course, there's a great amount of GDP that comes in through London. So we have these inequalities to address. We're a large and complex region. and as a network we're expected to cover all of it and all the specialties within it. Next. So the policies that we're asked to operate to are really values, participant-centered, and the integrated care systems have this approach, which is one patient with 10 diseases doesn't want those 10 specialists not to talk to each other, but would like a joined up system. Research is the same. I've just told you about place-based research in vaccines, where people came from many organizations to deliver, usually in the sports hall, the vaccine research. Our governance is based on openness and transparency with integrity, which helps our collaborative ventures and therefore our performance. We're expected and desired to be inclusive of all regions, specialties and areas of the population, although that's a huge ask. There are ways of gaining access to research, so the vaccine research used this be part of research national registry. 500,000 people said they were happy to join vaccine research, and when the studies opened there were thousands of people ready to join, which really speeded everything up significantly. Next. We've always had patient involvement at the design stage. At the delivery stage we have research champions who can help with the recruitment and indeed potentially consenting and feedback and so on. But also interested in disseminating findings. So I think that's already strong. Partnership working is a theoretical way that we are as a network, but in practice we've been siloed and competitive because of the way the metrics and money went. But that's our constant value added as a network, is to try and find synergies between partners to see if they will work together and we can promote that partnership for a greater outcome. The national collaboration has been very tight and centrally led through COVID. So one day Boris Johnson is announcing lateral flow as the way out of lateral flow tests as a quick way out of the pandemic. And they launched something called Moonshot Study. And the next day we were expected to have 10 of our research staff in a car park testing this new lateral flow. And that was the way that things have worked over the last year, very much dynamic and reactive and agile and centrally controlled. We seek to be transparent in many ways, but certainly financially. I'm happy to answer questions about that. And we mostly spend our money through our partner organisations. For example, Leeds Teaching Hospital Trust, or indeed Leeds University, both partners with contracts, and they receive a certain amount of money in order to fund staff predominantly. Next slide. We're expected to be consistent, of course, and research requires that in a protocol and in its ethical standards. Being responsive, a two-way process where we obviously seek to be responsive to you and others' contacts with us, queries and requests, but we do welcome responsiveness when we're going out, particularly to some of our specialty leads and principal investigators and so on. We are expected to be flexible, and we have a flexible workforce called the Agile Research Team, which has just grown or is about to grow by 100% due to this new funding, which is to do with social care public health, which requires an agile response. We're expected to constantly improve our efficiency, and that's been exemplified by the same money to the network for the last 10 years, whilst recruitment has almost doubled, and that of course can only happen by finding more efficient ways to work. Next slide. As we become more efficient, however, we don't end up doing the same work as we always did, only with less effort. We have to go further, do more, like the gentleman with the round ball. And that's a constant challenge for us, is continuous improvement. But as our business is research, and the whole point of research is to improve life and care and so on, then that should be one of our cultures, and we certainly are always happy to improve. We can keep improving in many ways and have had very rapid improvements in many spaces during this pandemic. The research culture needs to be more ingrained in the caregivers who've been exceptionally busy dealing with a pandemic and unusual care, but they have been amazingly supportive of research through the COVID crisis, and we hope there'll be a continuation of that recognition of the importance of research. We've all had to change our skills through the pandemic. If we're clinical, I had to train in COVID care, among other things. As a cardiologist, I have to retrain in various things every year, but also in research. Well, actually, I was a COVID vaccine researcher. It isn't my specialty as a cardiologist, but I was able to adapt and train. But we're being called upon to do this in order to cross some of the traditional boundaries. So, for example, in a teaching hospital, if we support multiple nurses who are in specialties and subspecialties of specialties, and the pipeline waxes and wanes, and those team members sit with not much to do whilst other team members have a lot to do, that isn't a good use of resource, but sometimes there's a skill requirement that needs to come into play, and we do support skill development in various ways. We are very evidence-based, tons of metrics on something called the Open Data Platform, which tells us day to day exactly how many people are taking part in research, how many studies are recruiting to time and target, etc., etc. And that now is a really good system. It used to be not so good, but we try and make our decisions about funding and other strategies based on those sorts of evidences. Next slide. So where are we in terms of national priorities? Urgent public health remains, I would say, the top priority. I mean, it's almost been pushed out by recovery, resilience and growth, but then we've got this Delta variant, which is 60 times more infectious, which is the dominant strain at the moment, that may or may not be as resistant to vaccination, etc. So there's still very active research going. There's 8 hubs doing vaccine research right now. One of those studies is the COVID booster study, which is happening here in Leeds. If you'd like to join, I was boosted 3 days ago, basically getting a 3rd injection. I've had 2 already, and it's to assess the need for a booster and also ability to resist new strains and so on. And so that's ongoing. Research in pregnancy, research in children, that's ongoing, and various other projects which are still in follow-up. The actual inpatient treatment platforms are, of course, doing less at the moment because there's less cases in hospital, which is great. We sort of have to remain alert in case there is this additional wave that we could talk about, but we hope it won't happen. So we haven't been stood down from this space. We have to keep ourselves research ready. We have to still deliver on follow-up of studies that are ongoing. And so that's an added amount of work to our usual research portfolio depicted in the recovery, resilience and growth window there. Between the first 2 waves of the pandemic, there was something called the Restart Agenda, which tried to get non-COVID research started again, but then we had another wave and it was impacted, of course. And so rather than have a restart agenda, we've got this recovery, resilience and growth. And that certainly is a 3-year program, the resilience and growth part anyway. There's obviously hope that the recovery might be quicker as we're trying to do it for the 2nd time. But you'll understand the challenges whilst we're still in various states of restriction and patients are shielding, etc. The hospital, of course, is busy as well, but we could come back to that agenda. We have been given more resource in the urgent public health space, more resource in the recovery space, and we are giving out responsive awards to unblock blockages and other things, largely through our partner organisations. Before the pandemic, we had priority diseases, which are basically 9 disease states, 10 with multimorbidity, that were taken to be a priority nationally. Included cancer, COPD, asthma, both types of diabetes, acute and chronic mental health, heart failure, stroke, multimorbidity, and the maps were used to show where the disease is the most, each of those, and where the research is happening or not happening. And we were invited to try and match more of this important research to areas that were currently not engaged or given the opportunity to join. That's ongoing. And then we have the 4th agenda, which is new. called the Transformation Agenda. And this basically is the brief to go to prevention of disease and care of people beyond the curative stage of disease or in parallel with that. So if you imagine that as a life course where the caterpillar is a young child and the butterfly on the right is an elderly person graduating or soon to graduate to the beyond, we focused on the first two elements, the middle two elements, and we really haven't gone upstream to prevention, and we haven't gone sideways and downstream to the social or care needs, and we're now asked to do that. We've been given another additional amount of money, which for us is almost £1 million, to grow the capacity in these areas. And we've strongly encouraged all of our traditional specialties to look at these elements, because there's always a prevention element in every disease, and there's always a care element in every disease. So just by moving sideways or backwards or forwards, it's possible for our specialties to engage with this agenda. Next. So our priorities remain delivering vaccine research, and Yorkshire and Humber has delivered more vaccine research than any of the other 15 networks. We've had great participation. I've told you about the 8 hubs. We've had global firsts, etc. So that's still ongoing, and pretty much all of those were with industrial partners, which takes us into the top right area. Of course, our industrial and other funding partners are saying, what's happened to our research? We need to get it going again. How soon can you get it going? Can you prioritize our study? And there is a managed recovery process where each of the funders are allowed to choose 5 of their funded projects to prioritize over others that they've funded. Technically, this is not a prioritization, we're told, but it's a managed approach, meaning centrally coordinated to try and facilitate this process of hopefully getting back towards normal. We continue to do our priority diseases, and that donut at the bottom were areas that we'd funded leading, prior to the pandemic, and they dealt with underserved communities and priority diseases. And then the transformation agenda, we were already really strong in that space, probably again more than the other 14 networks. We've been strong in public health and social care and non-NHS partnerships. So we're very keen to not hold back on that agenda whilst we're doing these other 3 things. So basically we've got a 4 priority agenda, when previous to the pandemic we would have done 1 of these or maybe 2 of them. We had previously worked at our own strategy and come up with a strategy to enhance research value for everyone called SERVE. That slightly has taken a back seat, but in other ways it's been strengthened by the pandemic, because the main way we can serve our communities is through delivering relevant place-based research, which is part of the transformation agenda and indeed these other agendas. So we're sort of in the right space, and we're seeing this as a big opportunity just now. Next. Just we are looking at how we can be helpful to you, but you probably noticed we don't do translational research in a test tube. There sort of has to be a human being involved if we're involved, I would pretty much guarantee. We are supporting early career researchers in different ways, and we've just completed a new program called First Steps into Research, which has been very successful. This has been for the research curious who might be NHS staff, maybe allied health professionals who really don't know a lot about research and are interested to find out more. And it acts as a first step, which can help people to move towards fellowships and other things. It'll be rerun at a much bigger scale in the next year. Next. We'll also have to use it to help build capacity in local authorities and in social care. All of those policies are available through the internet if you needed to know more about them. The added value of the network, I've said it is about trying to get people to work together. That is a bigger challenge than you might imagine. It requires psychological, emotional intelligence, among other things. There's a lot of egos that might choose not to work together. There's a lot of political siloed self-interest as well. Sorry, can anyone confirm that you can still hear me, please?
I can still hear you, Alistair.
Oh, good. Okay, so it's just the slides. Don't worry, I'll keep going without. So what have we learned through the crisis? Well, about the amazing partnership we've had within our organisation, but also with the public and with the healthcare providers. It's been a seamless partnership, which has been a real pleasure to be a part of. And we've also found new ways to be efficient. Remember that challenge to do miracles with peanuts? We've learned how to do that a bit more. So, you know, when patients can't come to attend for research visits or indeed normal clinical visits, next slide, please, Carol. The telephone and video consultation, of course, has really taken off. And I think that's also been true of our research methodologies and approaches. So we've learned to be more resourceful, more innovative, and there's every hope that we'll maintain not least virtual meetings like this and other things that will add to the value of what we do. Next. Because the BRC is an NIHR organisation and on your website you have training, the question is, can we add to that? We do have other services, but you know, training is provided essentially as well by the NIHR Learn. We do have a website where you can go and find out more about what we're able to do to support you. Next slide. We're involved in industry setup and delivery, and that may or may not involve you. But industry is more than drug companies. It's med tech and digital, and there's a lot of small companies in Yorkshire and Humber that would love to work in partnership. So we are encouraging that even on a small scale, and that could be an individual investigator. But at the moment we are again having to get most of our already started commercial industrial studies back up and running as best we can. The two people here, Dinesh is our industry lead medically and Tanya operationally. Dinesh is a consultant in Bradford and he leads something called the Biomedical, sorry, the Patient Research Centre. And I'm sure he'd love to partner with you in that. The patient research centres are just a year old, but they're preferentially given access to industry studies and invited to recruit at pace and scale. So they have certain ways of working which are innovative, digital and so on, and they would welcome partnership, I'm sure. Next. Yeah, study support services, don't read this, but basically for us to be able to properly support research you might be involved with, it needs to be adopted on the NIHR portfolio, and to do that it needs to be either funded by a recognised funder such as MRC, NIHR, a commercial sponsor, or otherwise adopted. The study support service are helpful from the moment of inception because there are forms and other things to navigate through the process. If patients are involved, there are certain costs that have to be considered and how they're being met, etc. It's a rather dull part of research for me anyway, form filling and all of this, but we have a very expert team that can help you through this process if you're about to set up or have set up a study or in the process. Next. I've mentioned the Agile research team. This operates on our three main footprints of West Yorkshire, South and East. The additional $1 million we've been given to expand into social care and public health is going to expand this Agile research team. And the idea is it's a pop-up workforce, but it can also be used to boost standard workforces. For example, the Born in Bradford project in Bradford has a long-term cohort, and they will be studying 30,000 teenagers within a few months. And of course, having a pop-up research team is helpful in such a circumstance, as opposed to having 3 people spend 3 years doing it. So this Agile research team has a website. It's possible to schedule or book access to it if you can anticipate the need. And the skill set of this group is broadening as we speak to include social care and public health type research schools, as well as more traditional hospital-based research. Next. So I've mentioned about the NIHR Learn website. It is available pretty much to everyone. I think you can go on there as a member of the public. For people, obviously, due to clinical research, it's helpful to have something called GCP, which is good clinical practice, and or consenting certification. Next slide, sorry. These are online learning modules that people can do in their own time. They're mandatory for anyone who is involved in direct patient care research. And you know, over the years they've improved in quality. I've attended about 1 million good clinical practice training sessions, which I've had to do almost every year for the last 30 years, and they have got better, there's no question, more accessible, more relevant. The informed consent workshop. Necessarily consent is an important entry point to recruitment if it's traditional research. In public health research, interestingly, it doesn't always involve consent. So, for example, there's a project with school lunches where a researcher went into the schools and took pictures of everyone's lunchbox, but it was all anonymized. So there was no consent involved in that. They were trying to see what children eat for lunch. And there are other public health projects such as leaving the streetlights on late or other things that are done in a bigger way that doesn't involve individual consent. Next slide. So as the BRC is predominantly, I believe, still musculoskeletal, you can see what I've put there is volume of research. It's weighted to do with complexity of research. It's an average over 5 years. And then we've got ranking along the bottom, and you'll see musculoskeletal is towards the slightly larger end of the spectrum. There are some much larger specialties, and they all are supported by a clinical research lead, but otherwise receive support through the partner organizations or, for example, our Agile research team. Next slide. Hemant Pandit is the Yorkshire and Humber musculoskeletal lead, and you'll perhaps be familiar with him. Donna Johnson is our research delivery manager who manages group 4, which includes musculoskeletal. And there will be an associate clinical director, that's someone helping me, who will take responsibility for this area to try and improve our rate of interaction. And then, of course, there's a national musculoskeletal and every other specialty group. With activity, so Hemant will sit on that and attend those meetings. It's helpful for national coordination and understanding pipeline in terms of bringing studies to our region. Next. That's it. So I don't know how we're going to handle the discussion, but there is a chat box, and maybe Carol, you want to come in and mediate again? There was a lot of information there. How relevant it is to any one of you, you know, will vary, especially if you're lab-based. You might be interested anyway in what happens downstream. The COVID vaccine research went from, you know, bench to bedside to routine in under a year. So we are in interesting times in that regard. I can't see anything in the chat.
So Alistair, thank you very much. That was an amazing presentation with a lot of information, and I've certainly learned a lot today. Can I just ask you something about the Agile pop-up research team that you have?
Yeah.
So if I was to be writing a grant now, do I need to incorporate those costs in that, or is that paid for by the CRN, or how do I actually understand whether there is people that can help me in my time frame, or how do we work that out?
Yeah, if you think that would fit your model, meaning you need a experienced research team and maybe quite a big one for a short time, that might be the right model than trying to plan in something else. The way the network was invented was we were supposed to facilitate around the research in terms of our funding, which is finding people and making the NHS research ready and so on. Obviously, it does change. So research funders have tended to know we're here, and then they only partly fund nurses and things. But there is a limit to the workforce. You know, not everyone can have as many as they want, their own research team. So the Agile research team gets around that. When it's commercial research, it is expected that the costs are recovered of any contribution that we as a network would make. That doesn't mean the Agile research team can't come and do commercial research. They can, but the costs need to be recovered, and variously they might come back to the network, although we'd only give them out again. So often they stay where they were earned, but just get repurposed in some way, usually within a partner organisation. And question?
Yeah, and on the call today, you know, the majority of the audience are early career researchers, and you know, some of the problems we have at the beginning is to do some pump priming work, you know, that we want to actually do a proof of concept study, or we want to do gather some evidence for some of our application forms for our fellowships. Again, would the Agile team be in a position to help us with some of that? Because we don't have a team that's around a potential study that isn't funded. Is that something that they can help us with?
So sometimes these pilots can be done as under the umbrella of something bigger. So for example, I know the BHF professorial chair, which is across the city, you know, might have pilot projects, and technically it's covered by that and gets on the portfolio that way. In other ways, being, you know, attached to a program loosely or otherwise can help get on the portfolio, in which case we can definitely support it. Otherwise, I guess our challenge is how many specialties and how many partners, you know, are interested in that sort of activity, and the degree to which we can prioritize it over already funded research.
A juggling act, as I expected the answer would be.
I'm not telling you we don't do that. We do it out of our strategic budget, which is smaller, and it does have to tick boxes more widely strategically. So let's say one of the people listening wanted to do an amazing prevention of, you know, musculoskeletal problems and managing their social issues. That would really tick, you know, 3 of our boxes right there, for example. Otherwise, it has to prioritize against things that do tick those boxes, as we've been asked to prioritize and been given money specifically to do those things.
Thank you. Don't see any other questions yet, so I have another question, and as well, if that's okay. So as early career researchers, sometimes people feel quite intimidated about contacting the NIHR, the CRN. You know, what's your advice of somebody looking for advice and wanting to contact the CRN? What's the best mechanism of that?
Well, we have many portals of entry. In the BRC, HEMANT is obviously probably known to people and hopefully accessible. That's one route. We have our research delivery manager, we have the study support team, etc. We have events where people come along and meet and talk to us. You know, if you're not sure, you can just sort of send it, and let's say it was sent to me because you've just heard me talk. I can always redirect it to someone in the team who might be better placed to answer questions. Does that help you? Excellent.
I think sometimes people don't know what questions to ask because they don't know what they need to ask, and also they don't know who to ask because they don't know the person. And I think sometimes, you know, that initial step of reaching out to an organisation such as the CRN is quite intimidating, and feeling that you don't want to fill up somebody's inbox with questions that particularly weren't relevant for them, but not knowing anybody else how to get in.
Understood. So I think if people, you know, how I would approach it is that I'd go to the website first that says CRN Yorkshire and Humber, and then I'd see what it's offering and how you access different things like study support or whatever. And I might pick a random one. If it's clinical questions, obviously we have this clinical structure with specialty leads and indeed PIs and others. Usually when I've been asked these sorts of questions, it's probably I'm not the right person to ask, which is how do I get an NIHR fellowship? So we don't give out fellowships. That's not us. That's a different part of the NIHR as such. So, I mean, we do have people within our structure who are very active in that zone, meaning they've got 2 hats on, of course. So it's not that we can't redirect or help in that way. Again, the NIHR website obviously will also give information there.
There's a question.
Yeah, I think we're getting a question there, but it's hidden by another pop-up. Okay, there it is. Do the art contribute to all aspects of research? That's the intention, absolutely, apart from they won't come into the lab and titrate things, I don't think. Although they did have to with this lateral flow test. They had to do all the lab work too. Quantitative, qualitative data collection, recruitment. Yeah, we really should be, whether we're fully tooled up for it, but we're happy to take that challenge. We are supposed to be finding with this extended agile research team people with other skill sets who would support qualitative research and social care research, school research, etc. So we're happy to be challenged on that, Simon.
And if I wanted to be part of the ART, how would that work? Do you advertise or?
Oh, that's good. Yes, we are advertising. Yeah, it'd be great. At the moment, we don't have any medical members of that team, although it's been discussed. It'd be a good thing. That's how we got through the COVID pandemic, is by employing largely middle grade doctors full time. Some were actually returned consultants who gave sessions and other things, and it's really helpful when people are otherwise busy to get research done. So the idea that we had a roving medically qualified person who could come in and do consent and other things that are otherwise restricted, that is something that we're considering. But otherwise, yes, the staff are largely, well, they've traditionally been research nurses, but also now clinical trials assistants and a wider range of allied health professionals moving forward.
Excellent. Eileen Tan has her hand up. Eileen.
Hi, Alistair. Brilliant talk. I really particularly like the imagery that you use in your PowerPoint. Amazing. Just a question to see if you can explain in very simple terms, in terms of if there's a charity funded or a study that comes to CRN and say, look, we're eligible for adoption and the study's adopted and they're asking for support, nurses or whatever it is, how does CRN then recoup the finance, the help that is provided to the study? Does it come from a central pot?
Yeah, so just to say that we're an unusual network in how devolved we are, because we were 3 networks and then we became 1. In fact, we were like 20 networks with the specialties too. There was a big political situation in uniting, but there was also you can't have someone travel from Rotherham to Scunthorpe every day to help with research. So we have challenges that way. So we have a devolved model where most of our money is at the beginning of the year given to our partners, including Leeds Teaching Hospital, and it's hopefully a similar or an increased amount to last year because there's already staff that are expecting to be paid. How that then is handled internally does vary by partners, and our smaller partners, let's say Airedale or one of the district general hospitals that maybe have 12 staff, have to be a lot more generic and agile across specialties and so on, whereas the big teaching hospitals tend to get rather siloed and say, these are our 5 subspecialty nurses and they only do whatever cardiac MRI research, but we don't do stent research in the heart or something. So there is a need for each organisation to internally keep alive some of the generic working that we've had through COVID, even if only in 10% of people's time or 10% of then it's possible to move them around. So again, in Sheffield, there's a different model to Leeds. They have a clinical research facility where pretty much they keep most of the CRN funded nurses, a bit like an agile research team. And then as projects come in, people apply and those people go out and support those projects. In Leeds, it's more embedded historically and probably does need to change a bit. Happy to talk to you about that as next time we meet. But you go to your own R&D department is the short answer in the first instance.
Oh, my computer's playing up. Thank you very much. That was a great answer. Does anybody else have any questions for Alistair whilst we have a few minutes spare? If not, or
can I just say, coming back to this, people being intimidated, yeah, I'm sure I'm very intimidating. I don't intend to be. I can be emailed through one of 3 email accounts, and as I've said, I can advance it to someone who's better able to answer the question, or as we're doing this session, we can take it as a follow-on to this if I can answer it directly. You should be able to find my 3 email accounts, but one's NIHR, one's university, one's NHS, and just use one of those. That's all right.
Thank you very much. That's really helpful, and I think, you know, it is as a bit scary sometimes to email a professor asking a silly question, but sometimes that's the only email address people have. So thank you very much for that.
It's all right. My first year students do it all the time. They're not intimidated.
So if nobody else has any other questions, I'm going to round up the session today. I'd like to really thank Professor Alistair Hall for his time. I've learned a lot. I'm sure everybody else has.